Hello, my name is Dr. Sarah Vinson, and I'm here to talk about social injustice and civil commitment. And I'll have a few slides, about 30 minutes worth, but then we'll have a discussion that will be equally as long and that I am really looking forward to having with you all about this topic. So often when it comes to civil commitment, which sometimes ends up involving the criminal justice system or things that feel or perhaps even are coercive on our side of mental health, there's this issue that comes up of diversion, right? How do we stop people from getting to that point, or how do we decrease the amount of folks who have to go through civil commitment proceedings? But as a child psychiatrist, of course, I think developmentally. And so when we're in a society where this is such a big issue, where we're seeing more and more mental health crises, and this is something that is of ongoing relevance, one of the questions that I hope we can start to ask is, why are there so many people in need of diversion or at risk of civil commitment in the first place? And so that starts with direction. Where were people sort of angled too early on in their lives? How did they develop in those settings? And how is that contributing to what we're seeing on the tail end of the issue? And with this talk, as you can tell from the title, it's going to have a social justice or social injustice rather slant. And so the question I would ask you to hold as we go through this content, and really as you go through the content throughout this conference, is how have social injustice, societal narratives, and social and systemic marginalization impacted those who are committed, those who are doing the committing, the systems that are responsible for this process, and the mental health care system as a whole. You know, we talk about the mental health system, but really we have a mental illness system, right? People usually don't enter it until they're quite symptomatic. And our discussions, even when we call them mental health, are often more centered on illness, symptoms, diagnoses, medication, interventions, treatment. But when we think about what mental health actually is, and this is a definition from the World Health Organization that I think is really helpful, it's a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her or his community. And so mental health is not just the absence of a mental illness diagnosis, and people could have a diagnosis and still meet a lot of these descriptors. It's not just, do their rating scale numbers go down, or are they compliant with their medication? There's nothing about that in this definition. The other thing I want to call your attention to with this definition is that it really is reliant on what's going on around the person. There are aspects of it that are going to be dictated by, or at the very least shaped by, systemic structure such as education, housing, employment opportunities, and so forth. And so when we think about mental health and mental illness, right, the other thing that our system, the mental health care system, forces us to do is say people have this diagnosis or not. And in reality, everyone is on a continuum. And when we're thinking about civil commitment, thinking about the populations that are disproportionately impacted by it, it's helpful to consider who is exposed to things that push people toward illness, and who has the benefit of things that promote their mental health. So on the side pushing toward mental health, we have protective factors, supports, and adaptive coping. On the side pushing toward illness, we have things like risk factors, stressors, and maladaptive coping. And we know these things take place at an individual, family, societal, and then even a countrywide level. So as we're thinking about mental health and mental illness with this broader lens, and I'm just going out on a limb that most of you are in the US, or at least are familiar with the American dream, even if you're not, just given kind of America's state in the world and its branding, quite frankly, in the world. Our ideas, right, of what this country is may be very different based on our experiences that may be very different. Now, I do think in recent years, for better or worse, some people who had certain ideals about America have had those challenged in ways that perhaps they had not been before. But it's important to remember that this is a society where there's this idea of rugged individualism is put on a pedestal. It's a society where there is a narrative that if you work hard, you can succeed. It's a society where there are thoughts about freedom and liberty and the fact that we have it right and we are a just and democratic society. And the people who have the benefit of going to medical school, going to graduate school, going to law school, becoming psychiatrists, becoming psychologists, becoming judges, are people for whom the American dream has often worked, either for them or for their family for generations, so they didn't even necessarily need it to. They just continued with the privileges they had. So the group of people who are in webinars like this and making decisions about who is committed or not are by and large a privileged group of people. And if they didn't start off privileged, they're people for whom the educational system gave them opportunities that their brain and orientation was able to take advantage of to change their station in life. Now, that is not a universal experience. Our experiences are not representative experiences of the larger populace, and they're certainly not representative experiences of the people who are civilly committed or evaluated for civil commitment. So when we think about society, right, we know that there is a stigma attached to mental illness or to living with a mental illness. And what we see in the mental health care system, what we see in the criminal justice system, is that societal hierarchies have a say. Often we pay a lot of attention to race, and sometimes that's where we are going to have the most data because of that. And there are things about race that make it useful from a social stratification standpoint, and that's part of why it was chosen. If you haven't read Isabel Wilkerson's Caste, that's a fabulous read along those lines. But there are lots of hierarchies, and there are ways that sometimes we can use things that we've learned from race to think about other hierarchies in society, right? So people who are in the position of making the diagnoses or issuing the order, right? There's a hierarchy between them and the person who's being evaluated for commitment. There's a hierarchy and a culture that is part of medicine and part of mental health profession. There's hierarchy certainly along class lines, around people who are differentially abled, and then we don't talk about it much at all. Our society most certainly suffers from adultism as well, right? Well, there is this bias often in favor of adults. There's this default to thinking that if a child isn't following an adult's orders, they're oppositional. We don't have a diagnosis that captures when a child doesn't respond to an adult well because the adult has been abusive of the child. There's the presumption kind of baked into our diagnostic criteria that the adults around them are well-meaning, reasonable, consistent, and don't ask them to do things that are harmful to them. And unfortunately, we live in a society where that is far from the universal experience of children. And I will add too, as a bit of an aside, when you're looking at studies and literature related to civil commitment, there's a big gap when it comes to children, which I think is another kind of illustration of how they are left out and not valued or centered. And so given that the populations that are facing these evaluations or these determinations are disproportionately impacted by being on the wrong end of these hierarchies, and that people who are the decision makers are disproportionately from people who are privileged, relatively speaking, it's really important that we mind the gap. So if you've ever been to London and you ride the train system there, there's this announcement that comes on over and over and over again that you mind the gap. It's a whole thing. There's like t-shirts and everything that say it. But it's so repetitive because it's so important, right? Because the consequences of not keeping that in mind are that you fall between the rail and the platform, which could be devastating, right? And I think the same is true when you have people making decisions about people's liberty, about people's treatment, about diagnoses that can follow them and have significant implications system to system. The power that you yield as a decision maker or someone who influences them is tremendous. And so minding that gap between the lived experience of those we are serving or working with and our own is critical. So social justice is one of those terms that's been a bit politicized, but I think if you're in the legal profession or you're in the mental health profession, fundamentally, this is probably something we can agree on if you look at what the actual definition is, or at least this one by John Rawls, which is assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. So we think about society and we think about social determinants of mental health. We've started to pay more attention to things that we know convey risk throughout the life cycle for mental health problems. Things like food insecurity, homelessness, climate change, adverse early life experiences, poverty. These are all things that we know are going to push more people in our population toward illness. And we've all seen this play out in a way in the past few years as we've experienced the collective disruption and trauma of COVID and seen how diagnoses have gone up. Even before COVID and we had this virus that we had to adjust and adapt to in real time, we had reams of data about the fact that these things are not helpful for people's well-being. We knew that these things were mentally toxic, to put it another way. And even with that information, our society, and I'm talking about the US society, that has tremendous resources, continued and continues to expose large proportions of our society to these things that we know are harmful. By the time we get to clinic or we get to court and we're doing ACE scores or we're doing trauma evaluations, it's really good that we're considering these things now. But at that point, the exposure and the increased risk has already occurred. If we're going to think about mental health as a population, if we're going to think about social justice and how it relates to it, one of the ways that it's connected is that the ongoing exposure of large swaths of our society to things that we know are harmful is mediated by the unfair and unjust distribution of opportunity, and I would add of resources. And that is fundamentally a social justice issue, and it is framed by public policies and our social norms. And we'll talk about some examples of that and how that contributes to this loading in the population of people whose symptoms are so severe, there are concerns about dangerousness or about their ability to care for themselves. And that there's all these folks who, for a number of reasons that may be and often are bigger than them, don't get intervention before that point. So when we're thinking about social justice and mental health and the crises that can lead to this question of whether civil commitment is appropriate, some things to think about if we take that broader lens. So characteristics and narratives of the larger society play a role. And so media, how people are depicted, how groups are talked about, policy about education, food, housing, and healthcare, right? If there's this idea that certain groups of people are redeemable and certain groups of people will always be that way, that's just how they are, then things that extend a hand of help to those populations may not be viewed as worth doing. What are people's experiences with systems, right? So if they're having to come into a hospital or into the mental health care system against their will, why is that? Is that because people don't want care or they don't know about it? Or is it because their experience of systems are different than people who are more privileged experience systems. So were those systems stressors or stepping stones for them? Have they been historically, when you look at educational, child protective services, or healthcare as examples? In the neighborhood, were there opportunities or threats? And when you look at home and peers, was there things like stability, appropriate supervision, and positive peer dynamics that played into how they saw themselves, but how they saw the world as well, and their place in it. So some principles of social injustice, and I welcome you to think about these as they could relate to diagnosis, as they could relate to how healthcare providers or officers of the court interact with people, or how they could show up in some of the medical or mental health records that you may be reviewing or considering. So essentialism, the belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization. And I'll give you all an example of that. Often we'll see in these admittedly well-intentioned cultural competency seminars when trainers will say things like, Black people do this, Asian people do this, Latinx people do this, as if this is not a very diverse, heterogeneous group of people under the umbrella of Black or Asian or Latinx. Biological determinism, the false belief that racial groups are biologically and genetically different. Erasure of context is failure to consider socio-historical context when seeking to understand the etiology of inequities. And a way that that shows up, right, is that in the instruments we use, in the systems we have, even if the individual who is the practitioner is not white, often the invisible norm or the perspective is one that is based on a white middle class experience. So for example, if we think about the first set of case studies that were done with those 10 questions, those 10 questions don't ask about things like neighborhood violence or experiences of racism, because it was normed on a largely middle upper class, college educated white population in Northern California. So the socio-historical context of that population has been left out of discussions of use of that instrument and some of the things that it asks about and some of the things that it does not. And then structural racism, right? A system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. And this is something that makes the study of inequities as it pertains to race really difficult, because when you're looking at confounders, even things that could sound as if they're race neutral, like prior arrests, right? That's a number, it is objective, right? But when you think about the disproportionate booking, interaction, conviction of people along racial lines, even though you're not asking about race, you're deriving a statistic from a system where race is certainly known to be a factor. And then types of oppression. So exploitation, which is the unequal exchange of one group's labor and energies for another group's advantage and advancement. Cultural imperialism, establishing the ruling class culture as the norm, othering of groups that are not part of the dominant culture. Powerlessness, when oppressed groups lack power and are blocked from routes to gaining it. Marginalization, which is expelling specific groups from meaningful participation in society. And we especially want to consider this when we're thinking about what are some of the implications of having an involuntary commitment on your record, and violence, threats and experiences of physical and structural violence. And what I'm talking about with the structural piece is when our systems and our structures, not when they're aberrant, not when something goes wrong, but as they are configured and routinely operate, actually act as instruments of harm. And a lot of people on the disadvantaged end of those hierarchies have not had good experiences with our society systems. And sometimes, understandably, it may be hard for them to believe that the mental health care system is going to be the one that gets it right.
Which doll is the black doll? And which one is the white doll? Which doll is the pretty doll? Which doll is the nice doll? Which doll is the bad doll? Which doll is the nice doll? Which doll is the bad doll? And why is that doll pretty?
Because he's white and he has 2 eyes.
Which doll is the ugly doll? Why is that doll ugly?
Because he's
Which doll looks most like you?
me
Yeah, which one looks like?
and that one.
Okay.
So that is a fairly recent recreation of the Clark doll experiments. And obviously in this example, the focus is on race and how early kids pick up on who is desired and who is not, who is othered, who is less than, who is by default associated with the negative things and with the positive things. Race is used here, but I welcome you to think about how this could apply to other forms of marginalization that kids pick up on too, right? And all of us at some point were these kids and continue to be these adults who are exposed to these messages of who is worthy and who is not. And the reason this is relevant, right, is because this doesn't just apply to Black children. If you did this with white children or with Asian children or with Latinx children, they would know who is favored and who is not. And we all grow up in this milieu, right, where we're getting these messages. And so, obviously here the questions are about ugly and smart and pretty, but it's not a huge leap to think about how that could correspond to ideas about who is dangerous, who needs to be forced to have treatment, who is antisocial, who is the diagnoses that are more stigmatizing, like schizophrenic, right? That there are ways that this can make its way into how we categorize people from our positions of power as professionals. So mental health inequities are disparities or differences in mental health that are a result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. And so the reason I point this out is we don't just want to say disparities and say, oh, that's a difference, that's interesting. If we look hard enough, if we think critically about them, we can find these systemic, avoidable, and unjust social and economic policies that are contributing. And in doing so, right, it can point to potential solutions if that is what we're trying to do. So when we think about the healthcare system, right, and we come back to this idea that you have people who have to be forced into it or who are so sick that they have to go into a hospital because they're dangerous to themselves or others. What's keeping so many people from engaging earlier, for getting the help that they need earlier? And what we see is that there are a lot of gaps, and I don't even know that gap is the right word, in our system, right? Where hospitals are is not necessarily where people need them to be. It's a business, and so it's about generating revenue. We know there's inadequacy of private and safety net systems in terms of coverage. And we have it documented. There are inequities by income, race, engagement, reception of evidence-based interventions, retention, forced hospitalization, forced medication, stigmatizing diagnoses, and early intervention. And I'm going to pick on physicians for a bit, and it's not that they are the only people in the mental health care system, and they're not even the biggest group of professionals, but I think that what you see here has relevance for how you think about just the professionals as a whole. So what you see is there's a mismatch of providers versus the population, with the medical profession reflecting the consequences of economic and social inequality of the US society at large. In 2019, only 5% of medical students reported parental incomes in the bottom quintile of US households versus 51% in the top. And from 2010 to 2016, the mean debt rose, but the percent zero debt also rose from 16 to 27%. So a quarter of doctors are from families that are wealthy enough to write checks for tuition and for living expenses throughout undergraduate and medical school. And when you look at the most consistent predictor of practice in underserved or marginalized communities, it's when people have connections to those communities. So we have a workforce that by default, not as a whole, no, obviously some of us do work in those communities, but as a whole is not primed to take care of the most vulnerable people at the earliest stages. And when you look at private health insurance, right, it is something that is a mediator of access to care, and it is concentrated among middle-class workers with skilled labor and white-collar occupations. Well, who is set up from a very early age to be in those kinds of jobs? And again, we see where that stratification comes into place by race and class and geography. So when you have a system that looks this way, that operates this way, and then you add on things like parity in name, but not in function, the result, right, is that you have a lot of providers who opt out of the system, with mental health particularly being impacted by people who just don't deal with the insurance system. With the proportion of mental health services received out of network is 3.6 to 5.8 times higher than other medical specialties. So what this means is that our workforce, the people who would canvass communities and provide care and be able to identify things early and intervene early, just isn't there. So in 2018, 69% of Black adults with any mental illness received no treatment, and 42% of Black adults with serious mental illness received no treatment. And again, using race as one of these areas of stratification. And 67% of Latinx adults with any mental illness received no treatment. And 44% of Latinx adults with serious mental illness received no treatment. Now, often when you hear discussions about this, you'll hear things said like, oh, Black and Latinx people, you know, they'd rather pray about it, or they have so much stigma, or they just need to be educated about mental health issues. But when Alang and his colleagues actually asked Black people why they don't get mental health services, cost was the most commonly cited reason for not seeking care. Twice as often as minimization of symptoms, and nearly 5 times as often as stigma. So something that is often framed as cultural resistance to engagement is really a failure of accessibility on the system that is supposed to be serving them. And there are implications for this, right? Because if you think that the problem is stigma, then a stigma campaign and billboards is your response. If you understand that the problem is that cost and structural barriers are disproportionately impacting different parts of the population, then the response is different and is one that requires more of us, our society and our systems. So Toni Morrison said definitions belong to the definers, not the defined. And when we're thinking about civil commitment process, the need to get it right falls on us. You know, the consequences are borne by the people who are being committed, but we have to take ownership of the language we use and of the way that it is applied to different people. So a very striking illustration of this, right, is how substance use disorder, same disorder, has been talked about in the broader society, but also in how courts and the mental health care system have responded to it. So we see a disparity here, right, in terms of empathy, news coverage, and that also reflecting funding and training gaps and how we've responded to the cocaine problem, where we talk about crack babies and mom being a threat to them, versus the opioid problem, where they're children, not crack babies. And it's an epidemic, and we're using medical language. And we have humanizing pictures of the people who are affected by it. Involuntary hospitalization, right, which is how someone who is going through it may experience it, versus civil commitment, which is how we frame it when we are talking about it. The experiences of people who have seen people they relate to, people who look like them, harmed repeatedly, graphically, sometimes fatally by state actors? Is this cultural mistrust, as it somehow sometimes described, and again, these well-meaning cultural competency seminars, or is this experience-based fear? And how does that impact how you see their symptoms or their diagnoses, how you respond to them, whether you're validating of what they've experienced or not? And that in turn can impact how they show up. And then assisted outpatient treatment versus what may feel like or be in reality surveillance of people that can make them feel dehumanized or less than. And we know more about, from what I can tell in looking at the literature, inequity in criminal court versus civil court, but I think there are some parallels here. Black and brown people make up the majority of people in jail in the US, and Black and multi-race people are disproportionately civilly committed. 80% of state judges are white, 86% of psychologists are white. Most judges acknowledge the system is racist. And in 2010 study, and I have the site at the bottom, healthcare providers reported less empathy for their minority patients. And so when the trauma isn't counted, right? And when the trauma is an ongoing thing, and our diagnostic criteria and systems don't acknowledge it. So things like race-based trauma, structural trauma, that can lead to problems with our diagnoses and how we respond to people. And so there are going to be things that the record reflects or that it may not. And so we often use this term treatment refractory patient, which for certain populations, it may be that this is recovery resistant or unjust care. So undercounted traumas, the ones that disproportionately impact marginalized populations, the ones that are disproportionately civilly committed, surface diagnoses, right? So things like bipolar or schizophrenia or antisocial personality disorder that don't account for mood symptoms or numbing or emotional dysregulation from traumas that have been experienced. Poorly managed symptoms, right? So rather than saying that the person is refractory or they're non-adherent, maybe they don't take the medicine because you're not listening to them when they tell you it's not working. And then the structural barriers that people can be up against, even if they want care, with costs being one that we just talked about, but really practical things like public transportation. So coming back to this direction, development, and diversion. So what can we do as mental health and legal professionals? Developing a knowledge base, understanding that we can't wing it based on our lived experience because they are not representative of the people that we are seeing and evaluating. Being aware of your personal bias as well. And there is data to show that if we're aware of it, we can account for it, but it's something we have to do with deliberation and from a good place mentally ourselves. Guarding against affinity bias, and this is our natural tendency to do more for people who remind us of ourselves, leveraging the privilege we have in order to address these issues, advocating for meaningful representation, and this could include race, disability, people's experiences with the system, and having lived experience with civil commitment, having them not only at the table, but making sure they also have a voice, response and concrete outcome tracking. So seminars are cool, but they're not the work. The work is actually changing what you're doing and seeing if what you're changing is resulting in a more equitable outcome. Advocating for systems change and then meaningfully involving family. But that systems change part is important. I don't know if I would go quite this far, but Edward Deming said a bad system will beat a good person every time. These are issues we need to take personally, but they're also issues that are bigger than us. And just something to keep in mind as you're thinking about reforms, as you're thinking about how you do these things, it is always critical to make sure you are getting data and information stratified by race, because a racist system plus a race-neutral reform will just result in a racist system 2.0. And understand that this work is hard, that there are people who are going to challenge, neutralize, or maybe try to undermine it. and that's part of the work. And I will end with James Baldwin, who said, "Ignorance allied with power is the most ferocious enemy justice can have. In your various positions, you have tremendous power. I hope that you see understanding and learning about these issues of social justice and hierarchy are critical to doing your job well." And thank you.
Well, welcome back. We're with Dr. Sarah Vinson again in our live Q&A session. If you have questions for Dr. Vinson, do put them in the chat. I'll try to read them as I can and get them into the conversation. Dr. Vinson, amazing talk. You've now told us what we need to do. I hope we have the courage to listen to what you said and follow your instruction. Would you start by telling us a little bit about yourself and your background and how you came to this work?
Yeah, well, the kind of normal stuff to tell you is that I'm a child and adolescent, adult, and forensic psychiatrist, and I've done a mix of public sector and private sector work in academia and forensic consulting throughout my career. But I'll tell you, what really informs this work is I'm the daughter of a probation officer and former police officer. That I grew up in a largely white rural suburb Monday through Friday, and was in hyper-segregated communities across the river with my grandma and cousins in predominantly Black neighborhoods in the weekends. So these issues of inequity and different experiences with systems and social determinants and health, they've always been a part of my life. It wasn't until I became a professional that I had the words and the terms to kind of attach to it. But I think that early exposure in those experiences definitely shape my work and my approach to it just as much as, all those years of training at Harvard and Emory and UF and all that.
You did go to some fairly amazing schools and are an extraordinarily, your training and certification is quite extraordinary. Congratulations. And tell us about that time of becoming who you are professionally. Yeah,
so I did undergrad at Fort A&M University, which is a historically Black college, which I'll say was, I started med school early, so I wasn't there the full 4 years, but it was a tremendous experience for me because it was the opportunity to be in a bubble where racism was really removed in a way that crystallized how much of a burden it was in regular life. So went from there to med school at University of Florida, did general psychiatry residency at Cambridge Health Alliance, and while there had the opportunity to learn under Dr. Judith Herman, who conceptualized complex PTSD, and then did child psychiatry and forensic psychiatry at Emory School of Medicine. And since that time have just learned more and done more in the mental health, but also quite a bit at the legal mental health interface as well.
And you've shown us that this work that we do is inherently political. And we have thought as an industry that we were above or beyond or absent from that. That has, I think, penetrated over the last couple of years. And now it's right in our face every day. And so these ideas and thoughts that you brought forward are really on the mark. Can you speak a little bit about, and going to the beginning of your talk, about the distribution of opportunity and go into a little bit more depth about that?
Absolutely. So it's one of those things where even though the narrative is, anybody can work hard and have X, Y, Z, we all know that's not true. And I'll give you a very concrete example of it. There's a reason that people pay $50,000 a year for their kids to go to private school, or pay triple the amount in property tax insurance for a good school district, right? They know that opportunity is not fairly distributed, and that environment matters. And the people with the resources have the privilege of choosing the environment in a way that advantages their child. And they do it all the time. And I'm not faulting people for doing that, but it's something that really flies in the face of the narrative that it's the same for everybody, and all you have to do is work hard and you'll be fine. And in that trajectory, right, that the school system helps to set up is one that some educators argue points to it being a system of replicating existing social hierarchies more so than one of helping people move out of them or move up or through them. So when we think about things like intergenerational trauma, exposures to risk factors, if people can navigate a mental health care system, or people in their family are in a position to help them do it, that is a system that is going to have a lot of bearing on it that we don't talk about, as much. But all those adults were teenagers and kids at some point that were in a system that, depending on where they are, might have missed diagnoses of learning issues or intellectual disabilities, or things that set them on a trajectory where they were going to have a lifetime of increased exposure to adverse social determinants of mental health.
Lots of questions in the chat about better models. And I'll start by asking, it appears that and that we really do need to look not just at the severe mental illness, but also at the trauma that people come to the conversation with, and maybe also other things like the addiction or the learning disability, or the educational cultural background. Could you talk a little bit about models that you've seen for addressing trauma for people who are really very sick?
Yeah, I think that if you think about trauma and you consider people who are in the civil commitment system or the criminal justice system are overlapping, they bear a disproportionate burden of it, right? And the way that I encourage people to think about trauma is, with this population in particular, is that you want to use universal precautions. So the same way you wear gloves with everybody because you're not sure who has what or who's been exposed to what. Certainly when you have a population that is loaded with folks who have experienced more of all the isms, there should always almost be a presumption that it's there, and everyone should be treated as if that's a possibility, right? Because one of the things that we rely on sometimes in the mental health care system, and in society more broadly, but the implications are different in our system, we rely on people being able to articulate what has happened to them and trusting you or the system with that information, right? And so you can't go by whether someone discloses it or whether it's in their chart or whether they answer yes when you ask them the question, because there are all these different things that could be getting in the way of it. But when you look at who is most affected by these laws, by these statutes, it's a group of people that we know as a population has experienced these things. You may not know what it is, right? But you do know that they're extremely high risk. So with that in mind, really going through procedures and thinking about how they may recreate things that evoke feelings of powerlessness or helplessness or the inability to move, right? Like basic things that would be difficult for any of us, but that may be loaded and triggering in a different kind of way for people who have gone through different forms of abuse.
Just a moment more about trauma. We've been the mental health system has been experiencing a growth in peer movement, and it seems to me that I'm not the right person to talk to someone about the trauma of having been in prison, because I've never been in prison. Can you talk a little bit about the value of peers in this sort of work, in doing both outreach and being part of the treatment team? Yeah,
and I want to touch base about the part about the experience gap too, because there's a humility that we should bring to experiences that we don't have, but we can't afford not to talk about or address the experiences that we don't have, because they may be very central to who that person is, how they see the world, what their expectations are, right? So we have the privilege of opting out, but they don't, because it's part of their life and part of their world. And so it can be uncomfortable, and you do have to guard against being presumptuous, but it's important that we don't stay away from things just because we can't relate to them. Because for people who have experienced these things, missing that is going to make it difficult for you to understand them as a whole. So the second part is, I think peers are critical, not only, at the criminal, legal, or civil mental health interface, but in the mental health care system as a whole. My hope is that as the calls for more mental health services and more mental health intervention continue to increase, that peers are more fully incorporated into the mental health care system. I don't think that we can meet the gap between the service needs and where the system is without meaningfully incorporating peers. And I think that when you talk about representation, it's an area that's often overlooked, right? But that's an area where you need to have representation as well. And so, I think that is a key part of it. I will say that in speaking with people who have been peers or served that role on teams, one of the things that some of them have described to me is not feeling as if their voice is honored in the same way. And so when you have them, as I mentioned in the talk, not just giving them a seat at the table, but a voice as well, and guarding against diminishing their credentials, right? Because they don't come in the forms of letters and diplomas in the way that we're used to credentials coming.
Marvelous. A lot of comments in the chat, reactions to your short film about the Daleks test. Could you speak a little bit more about that, and how it's just very effective? And we've all seen that long ago in school, but it's just heart-wrenching.
Yeah, and so, part of why I show that is because I think there is a hope, and maybe in some ways that's been dashed recently, but there's a hope that we have moved on, or that we're better, or that society has made all of this progress. And there are some ways that it has, there are a lot of ways where it really hasn't. And that the background of that experiment is interesting because, it was used to help argue for the desegregation of schools, right? Because it was showing that there's harm to Black children of segregation. And it was used effectively for that, right? Like on paper, schools are supposed to be desegregated. In reality, they're essentially just as segregated as they were in the mid-1960s now. So the kids' response in the experiment is the same. The societal issue that experiment was used to try to combat is the same. And we continue to be a society that is, rather entrenched in these hierarchies. And so we can't have this hope that kind of paints things in broad pictures because that's more comfortable for us to feel. We have to confront head on the fact that this reality is here. And since it's here, what do we do about it? How do we guard against it? How are we proactive and deliberate about operating in a society where we know this is what we're up against? Because the default, right, is to go along with the status quo, and the status quo by default is one that is inequitable and unjust. When we were writing our book, Social Justice and Mental Health, that was originally how we pitched it to the editor. APA Publishing was going to be Social Justice and Mental Health. And as we were editing all of the different chapters, it became really clear we weren't writing about justice because it was just example after example of injustice. And so that's why we changed the name of the book, because social justice didn't reflect it, because we're talking about our society and justice is not reflected in our society.
I appreciate that your first point was to delineate the difference between mental health and mental illness. Very different things.
Yeah.
We a lot of questions in the chat want to know if you have seen a better model for civil commitment, either somewhere in the States or somewhere outside of the States.
I have not. I am not. And part of what I'll say, I think the challenge is, you know, we have 50 different civil commitments in the country. And then depending on who the judge is, right? Like on a given day, it can change. And so it makes it really hard to do model to model comparison when there's so much variability. Even if you look at civil commitment rates by state, you know, some states are 10, 20 times fold higher than others.
Right.
I don't think the people are 10, 20 times fold right. But who's right? I don't know. But it makes it really difficult to compare apples to apples. You know, some things that I think would be helpful for any group to think about if they're thinking about reform or models is to be intentional about having it be a trauma-informed system. And SAMHSA has resources around doing that, to be intentional about counting and accounting for hierarchies in your accounts. It's been, I won't say surprising, but it's been disheartening that as I've had a lot of these conversations the past few years, and I asked people, well, what do you know about civil commitment by race or ability status or socioeconomic status or neighborhood? Most of the time, they don't have those answers. They don't have those numbers. They don't have that data, right? So how are you going to address it? How are you going to know if your efforts to make it better are working if they're not quantified? And so anytime you're making changes, decide on the front end, we are going to measure for these things. And we're going to look for things that don't look like they're race-based or language-based on the surface, but where when we dig deeper, they are. And the other thing I'll say too is really, in coming back to that peers issue, if we're trying to close that gap, right, between our lived experience and the experience of people we're making these decisions about, having people with that perspective at the table, I think, can be really helpful in terms of identifying those gaps. And so I would say, and this is just, you know, me talking, I can't cite you a paper that says this, but I would say that having people who've been through that process on the other side, having their family members at the table is going to be part of building a good system. Brian Stevenson talks about how the people trying to solve the problems don't have proximity to the problems. And we think we have proximity because, you know, we work in it, but we work in it and we go home at 5 p.m., right? The people with proximity are the people who've lived through it and the people who love them. And so making sure their voices are brought in. So
the reform agenda is trauma-informed, get the data, include peers at the table, include family members at the table. Yeah. Dr. Cohen, Professor Cohen from UCLA yesterday talked a lot about that there's really very little data, comparable state to state data, and very little public data around civil commitment. But you spoke earlier about the overrepresentation of Black men in civil commitment. Could you talk a little bit about that? I've heard that too. I don't know where that comes from.
Yeah, so there's a fairly recent study. It's in Psychiatric Services, and I can get you guys the site, that looked at some hospitals in Boston. It was the largest study that they said to date that looked at that. And they accounted for confounders like socioeconomic status and referral source and things like that. And even after that, Black or mixed race held a higher risk of civil commitment. And so the fact that there isn't data, though, is telling in and of itself, right? Because we pay attention to, we manage, we value what we measure. So if we are taking away people's rights and we're not measuring it, that tells you something about the people who are being impacted by it.
I'm going to send you Dr. Cohen's. It's a little bit mind-blowing. So to sort of wrap up, it sounds like we need universal health care. It sounds like we need a social reform movement. And it sounds like we need to expand our ability to bring clinicians of various sorts from diverse backgrounds into the business. That's a big agenda.
Yeah, it is. But when you think about what you're being entrusted with, it's a big responsibility, right? And so the gravity of the agenda parallels the gravity of what we're doing.
That's the line from Spider-Man: with great powers beget great responsibilities.
Absolutely. Absolutely.
Dr. Vinson, this has been wonderful. Thank you so much for enlightening us and giving us charting us a path forward. A lot of us are we just work every day, and the big picture doesn't come into our frame on a regular basis. But this is how, these words are how we set policy, how we protect people in our charge. Thank you so much for being with us.
Thank you.